capitalize on that. The 4M's framework is applicable regardless of the disease the person has, regardless of their background, cultural background, racial, ethnic, educational, social, and can be incorporated into existing care. You don't have to add infrastructure. You don't have to change much what you do. In fact, when I talk a little bit more about it, you will say we do it. And I will agree that you do it. You just have not branded it that way. You just have not organized it that way. You have just not structured it that way. So that is all you need to do. So it's a shift in focus. It's not a program. It's not something new that you have to create. And you have to implement all 4M's together to make it ideal. You should not be picking and choosing one or two or three out of these 4M's. As I said previously, most health systems already practice some of this. It's just not structured or branded or organized that way. And this needs to be practiced reliably. So on all older adults, with every contact, with every part of the healthcare system, and across professions, across not just within medicine, but outside medicine, and across specialties within medicine. This is a dot map of the United States showing you where level 1 healthcare systems exist. Because each time a system gets approved for level 1 recognition, it comes up on the map and it comes up on their list. Now I'm going to focus on the state of Florida. That's where I live. And you'll notice there are quite a few there. And that's one of the most popular states with older adults. And now we are focusing on Tallahassee. The healthcare system there sees a lot of older adults. But there are not many healthcare systems that are recognized as age-friendly. My university faculty practice at the Department of Geriatrics is one of those 5 docs that you see there. The local hospital system, surprisingly, is not. So what are the 2 key drivers of what will make this happen? One is assessing the patients for these 4M's. The other is doing something with that information, creating a care plan, creating some action steps. These are the 2 key drivers that you know your patients regarding these 4M's. So you're screening, assessing for these 4M's. And with that information, you're doing something about it. You're not just banking it in a medical record. So both have to be supported by documentation and communication across care settings and across specialties. So if a patient sees a cardiologist in your healthcare system and then sees a neurologist and then sees primary care, this should be practiced consistently, reliably across all professions and across all care settings. Patient is seen in the outpatient clinic, then goes to the hospital, comes back to clinic. Again, both the clinic and the hospital need to be practicing it. So what do we mean by what matters? Knowing and aligning the care of an older adult with their preferences. And we will say we do that already. Yes, we do that. But when do we do that? Close to the end of their life. That is when we go asking about certain things. You don't have to answer this question. But how many in the audience, when seeing patients, anytime during that trajectory of when you've known them for some months, years, whatever, have you asked about their future health goals? I will tell you that I never did before I became a geriatrician. I will confess. Geriatrics training taught me that. And in any other profession, even in a simple job interview, they're used to being asked, where do you see yourself 5 years from now? Where do you see yourself 10 years from now? What are your goals for your career? Do you all agree on that? Have you all answered some questions like that sometimes? Okay. How often have you asked our patients, what is your future goal for your health? Where do you see your health going? How would you like your health status to be? Sometimes when you ask your patients those questions, they will come out with things that are related to their daily functioning. I want to be able to attend, and especially talking about older adults, my granddaughter's wedding, my grandson's graduation, my son's transfer, whatever it may be. It will not be that I want my hemoglobin A1C to be less than 6%. It will not be that I want my systolic blood pressure to be less than 120, right? So if we don't ask, they don't tell us. Now, we can have all sorts of excuses. Even my trainees have excuses. Dr. Suchak, we are doing this genetics rotation with you for 4 weeks. We'll meet this patient one time in your clinic. We haven't developed a rapport. We don't have a relationship. And this type of conversation requires a relationship. So how can I ask such a question? I said, when we could ask you these questions in your admissions interview, when we didn't know you at all about your future goals, you can very well ask a patient in one interaction towards the end of that conversation. So rather than finding excuses, we need to look for opportunities. I'm not going to go over the details of the next few slides. The font is intentionally very small because these are screenshots. But this is to tell you that the Institute of Healthcare Improvement has a lot of resources on their website, publicly available, freely available. There is no charge for anything, and they give you multiple options. So communication skills, conversation with patients, I consider them to be the hardest of all skills, because we learn about them the least, we practice them the least, and then we fumble in front of patients, and then we find it hard to say the words. So if you're going to be teaching this to your trainees, if you're going to be doing this with your patients, similar to when you learn how to do phlebotomy, how to do lumbar puncture, how to pick up a scalpel, make an incision, how to use the urinary catheter. We consider medicine to be a performing art. We are always performing, but we focus on interventions, physical interventions, and we forget about communication skills. If you don't practice your nonverbal behaviors, if you don't practice your verbal speech, the words don't come out, the compassion doesn't show, the empathy is not there. So like any other skill, it needs to be practiced. And that's why these resources are out there, so that you can choose, select, figure out which resource serves you best. So there are various conversation starter questions, sentences that you can use. So these are all resources that are available there. I just put them up so that you know the variety and the richness of resources of having these conversations. In the past, we have usually used these conversations towards the end of life, as though that's the only time you need to talk to your patient about what matters to them. If we had those conversations earlier, we would not be doing them when patients are panicking. We would not be doing them when patients are emotional. We would be doing them well in time, and we would be well prepared with advanced care planning. Also, why should conversations focus only on things when things are bad? Why would we not want to promote wellness and health? Why would we not focus on that? Why would we not tell our patients that this is what can make your state better than even what it is now, even though you don't have a diagnosed condition? So again, there are guidebooks, there are a lot of resources. What about medications? If a medication is necessary, I love these 4 words. To me, that says it all. If a medication is necessary, What does that mean? Before you take out your paper prescription pad or before you use your electronic medical record to send a prescription to the pharmacy, think about whether you actually need to treat this with a medication, because there are non-medication options. And also figuring out how that medication should have the least negative impact on mobility and mentation. So the 4 M's are interconnected with each other. Again, for the next couple of slides, I'm not going to go over the details. These are meant to tell you that there's already enough information out there that one can utilize. You don't have to create new action steps for yourself. There are certain basic principles of prescribing. Start low, go slow, try not to use 2 medications at the same time. Try not to treat the side effect of one medication by starting a second medication. And then in the United States, we have something called the Beers criteria, which is very specific and related to adverse effects of certain classes of medications that may impact older adults. So our prescribing habits for older adults are governed by that. And we refer to this document frequently and to the summaries. And this gets revised every few years. There are additional geriatric prescribing principles. I have put some samples out here. I've mentioned some of this already, and I don't mean to give you a lecture on geriatrics, pharmacology, or prescribing habits. But again, this is just to tell you resources are readily available. Again, prescribing principles, how to do a medication review, and what to look for. Sometimes we do something called medication reconciliation, and we think we have done a medication review. But all we are doing is checking. Are you taking this medication? Is this the correct dose? Is this the correct frequency? Check, 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 and it's done. That is not a medication review. That is called medication reconciliation, that you're matching your list in your electronic medical record or paper record with what the patient says they're doing, or you're matching it with what the pharmacy has. A true medication review would include some additional information. Number 1, is the medication really necessary? Number 2, are they having adverse effects? Number 3, is it effective? I could go on and on, but that is what a medication review would be. And again, one does not have to do this with every contact, especially if the patient is on a stable list of medications. One could maybe do it once a year. None of these items are meant to be burdensome. Mentation, the 3 Ds in geriatrics for mentation: screening or assessment for dementia, delirium, and depression. And depending upon the healthcare setting, hospital, outpatient, 1 or 2 of them would be more prominent compared to the others. We would focus more on delirium screening. In inpatient settings, we'll probably focus more on depression and dementia in outpatient settings. These are the sample screening tools, the confusion assessment method, and the new desk scale regarding delirium instruments. Again, this is not meant to be prescriptive. This is just meant to tell you that these tools exist. There are multiple depression screening questionnaires, including one specifically designed for older adults called the Geriatric Depression Scale. One thing to remember about such screening instruments, and when I'm done talking, I would like to hear your experience with it, especially when you are training trainees on the use of standardized instruments. Sometimes it is very hard to stick to the script of that instrument. So you're asking the patient about hopelessness, you're asking about them losing the desire for pleasurable activities, things like that. And some of these questionnaires have a yes-no response. It's very easy to get sidetracked when you're using these instruments and start doing what we call the history of present illness regarding that one item. So we teach our trainees